Hello, everyone, and welcome to Cancer Speak, the official podcast of Cancer, a journal of the American Cancer Society. I'm Dr. Christopher Lee, your host for today's episode, and I serve as the section editor for Cancer Prevention and Epidemiology for the journal Cancer, and I'm an epidemiologist here in Seattle at the Fred Hutchinson Cancer Center. So I'm very pleased to be joined today by my colleague, Dr. William Grady, the lead author of a new commentary in Cancer titled Top Advances of the Year, Non-Invasive Colorectal Cancer Screening Tests. Dr. Grady is also here at Fred Hutch, where he focuses on colorectal cancer prevention, treatment, and early detection. Dr. Grady, welcome to Cancer Speak, and thank you so much for joining us today.
Glad to be here, and thanks for the invitation. As you know, I am a professor of medicine at the University of Washington and the Fred Hutch Cancer Center, practicing gastroenterologist, and so very interested in colon cancer screening. And I have a research program that I run studying biomarkers and development of biomarkers based on work we do in our laboratory, looking at the molecular changes that occur and where they might be turned into biomarkers for cancer early detection.
So to start, can you give our listeners a brief sense of what this commentary covers and why the past year has been such an important one for colorectal cancer screening?
Yeah, my pleasure. Colon cancer is one of the common cancers, which is why we recommend doing screening for it. And there are current screening tests available that are effective, but one of the issues that comes up is that not as many people as we recommend participate in screening do get screened. And so what's been really exciting about this last year is the development of some non-invasive colon cancer screening tests that we think have that opportunity to include participation, or what we call compliance with colon cancer screening.
Colorectal cancer screening, we know, saves lives, but many people still don't get screened, as you just said. So from your perspective, what are the main challenges with our current screening options, and why is there such an urgent need for better non-invasive tests?
Those are really great questions, and part of the reason why we're so excited about the things that have been published over the last year and a half. About 150,000 people a year will get colorectal cancer. And we know about 50,000 people per year will die from that. And so that's where the need is. So we have 50,000 people who are dying, and we have methods right now that can prevent almost all those colorectal cancer deaths. And that's because we have a very effective screening test called colonoscopy, which is very sensitive and specific for detecting not only colorectal cancer, but also the significant precancers, which are called colon polyps. And there are different types of colon polyps that are precancerous. We can find those precancerous polyps and we can remove them during colonoscopy and prevent the majority of colorectal cancers. So the urgency is that we have people dying essentially needlessly because they're not getting screened for colorectal cancer. We know that another reason why there's an urgency to it is that we're seeing more people getting colorectal cancer of a young age. And so that has a big impact. They're not only those people, but also their families. Another reason why we're paying more attention to colon cancer screening than ever before. The challenge is, how do we then improve our ability to get people to do screening if we know that it's already effective? And this is where there are barriers, unfortunately, to colonoscopy. And there are a number of them. And the consequences of all these barriers, which are the logistics, the expenses, the preparation, the fear of colonoscopy, although I think once people finally go through it, it's actually a very not an unpleasant experience, except for the preparation. And for all those reasons, we think having non-invasive tests, so non-colonoscopy-based tests that would be agreeable to people, would be a way to get those people who aren't doing colon cancer screening now, which amounts to about 60% of the population who should be getting screened.
Just kind of a follow-up question to that. To what extent are issues around just capacity for delivering colonoscopy challenge in our country or even globally?
Up until recently, it was not a big challenge in this country. We could pretty much meet the colonoscopy burden that was present. But we've had, with our aging population and also with the reduction in healthcare providers, and particularly we've seen overall fewer healthcare providers practicing. And that was something that happened after the COVID pandemic. Impact of that is that there are some areas where colonoscopies are not available. They tend to be in rural areas. Usually in the urban areas, it's more accessible. But even then, to get a colonoscopy, there's quite a long wait time. And so that also can decrease people's participation. That's the issue in the United States, but in the rest of the world, it's actually even a bigger issue because they're not quite as well resourced to provide healthcare. They have more financial limitations. And so they're not only looking for less expensive ways to do screening, and colonoscopy, unfortunately, is quite expensive in order to meet the cancer prevention needs of their population. populations.
So your article highlights two studies that demonstrated the ability of stool-based tests to accurately detect colorectal cancers. So what do you find most exciting about these developments, and how might they change the way that we think about kind of non-invasive screening, moving away from colonoscopy and its time and expense that's involved with that?
The reason why I'm particularly excited about the studies that came out last year and a half about these stool-based tests is that they're a change to what we already have available. So we've talked about colonoscopy for colon cancer screening, but there are other non-invasive or non-colonoscopy-based tests. And those are predominantly stool-based tests, where essentially, you poop in your toilet, you collect part of that stool sample, and then they could be analyzed in the laboratory to identify whether there's anything in it that indicates that you may have colorectal cancer. So there's a current test that's already available, and the one used most widely around the world. It's called the fecal immunochemical test, or the FIT test. And that's fairly accurate for detecting colorectal cancer. It can detect, if it's done on a regular basis, and we do recommend that this get done every 1 to 2 years, it can detect 90% of colorectal cancers. It's not quite as accurate for those precancers, and that's an issue that makes it not quite as good as colonoscopy, because it's only about 20, maybe up to 30% sensitive for detecting those precancers. And that's an opportunity to prevent that cancer from occurring. As a consequence of that, the FIT is not ideal, but it does get used widely because it's much less expensive than colonoscopy. So there's a second test that's available in the United States called the Cologuard test, which is multi-target stool DNA test. So the fecal immunochemical test is based on detecting hidden blood, essentially, in the stool. But the Cologuard test detects not only hidden blood, but also DNA from the precancers and also from the cancers that are present in the stool. It's significant because it improves our ability to detect the colon precancers, which are those polyps. It basically doubles, a little over doubles the sensitivity. So now we can detect almost 50% of the significant, the large precancers. And so ideally, we'd use that test. Now, unfortunately, it's quite a bit more expensive, which is still a limitation in terms of its implementation and overall kind of impact on the ability for people to get screened, because fewer insurance companies will pay for it, and there might be a slightly higher out-of-pocket cost. So the two studies that were published in the last year go beyond what's currently available, the Cologuard test and the FIT test, and that they add an additional test called ColoSense, which currently is not commercially available, but is FDA approved for colon cancer screening. And it's based on a different analyte detecting stool for finding those precancers and cancers, and something called stool mRNA, which is another substance made by tumor cells. And its performance is a little bit better than the Cologuard test. And then the Cologuard test underwent a revision to try to improve its performance, and its new version called Cologuard Plus, which is commercially available and being marketed under that name, is slightly better for detecting the precancers and more accurate for detecting colorectal cancers. It has a higher sensitivity for them, but also it's less likely to cause a false positive result, because sometimes what happens when you use these stool tests is that you get a positive result, but the person doesn't actually have the polyp or the cancer. That's a big issue for places that have a limited colonoscopy capacity, because then they struggle to test those people who have positive stool test results, but ultimately don't have colon cancer. So they would like a test that minimizes that false positive rate. Those are the things that are really exciting about these stool tests. So we've got better stool tests now, a little more accurate, will improve our ability to do that screening. So when someone does get screened, it's more likely that we're going to find those precancers, we're going to find those colon cancers.
And do you know when the new test will be on the market?
The stool-based test, Cologuard Plus, as I mentioned, is already being rolled out, and it will essentially replace the current Cologuard test. The ColoSense, I don't know, and unfortunately, it's gotten caught up in some legal wrangling with regards to the test. So that, I think, has been a barrier for getting that rolled out. It makes me concerned about whether that ultimately will happen, because the test was FDA approved over a year ago. I would regret, because I think there's an opportunity to actually improve the cost of the test with a little bit of competition. Fingers crossed that would be available, but we're not quite yet, and we're not quite sure when.
And then, since these are kind of our currently available tests, and there's a lot of concern about the rise of early onset colon cancer in younger people, is there any variation in the performance of these tests by age, or are they sort of similarly effective?
And that's a great question. And we don't quite know, because the way a lot of these studies were done was using the test was benchmarked against colonoscopy. And so the studies were done on people who met screening criteria, and the screening criteria up until a few years ago were people over the age of 50. And so the group of people who are getting colon cancer more commonly now are predominantly in the group that are between 50 and 40, and even for some people lower than that, but the numbers are a lot less when we go to that less than 40-year age range. So a lot of the trials weren't done with the people between 40 and 50. And more recently, those trials have included people over the age of 45, which is the age where we recommend colon cancer screening now. So we're getting some sense of how the tests perform in that group. And then the more recent clinical trials that have been run have also enrolled people between 40 and 45. So that's a long-winded way to say we're starting to get information. It's not quite as robust as we'd like, but it suggests the performance is just the same in that young group as it is in the average age group. The other thing to be aware of, though, is that the way these tests work and the way they detect the stool DNA, they look for something called DNA methylation, which becomes more common actually in all the cells in our body as we get older. So something to be aware of is that those tests that use DNA methylation as a way to look for or detect the DNA from the tumor cells become less specific in older people, which means there's a higher false positive rate. So that's a challenge because those are the exact people that we don't want to be doing invasive interventional medical procedures on.
So we've talked about colonoscopy, we've talked about stool-based tests, but one of the other very interesting trials is this ECLIPSE trial evaluating promising cell-free DNA blood-based testing for colorectal cancer screening. So how do you see these kind of newer blood-based tests fitting into current practice? Are there certain key limitations that we should be aware of? Or what do you see as the future of moving away from either even colonoscopy and blood to maybe an even easier test, which would be a blood-based test?
That's a really exciting area that I've been thinking a lot about. And just for full disclosure, to let people know, I played a key role in the clinical trial, the ECLIPSE study. And the reason why we're particularly excited about these blood-based tests for colon cancer screening is this is essentially a new option. I say essentially because there actually is already a blood test that's been currently available and FDA approved for use called the EpiProColon test, but its performance is so poor. Its sensitivity for colorectal cancer is poor and its specificity is poor that it doesn't get used clinically. And so this new blood test that was evaluated in the ECLIPSE trial showed that it could detect a little over 80% of colorectal cancers, and it could detect around 13% of colorectal polyps. And so the performance was particularly exciting around the colorectal cancer detection, which is about the same as the FIT test. And so we think it's something that is equivalent essentially to FIT for colorectal cancer detection. It's not quite as good as FIT for detecting the polyps and not nearly as good as colonoscopy. And so then the question becomes, why would you do this rather than the stool-based tests, which are more accurate for detecting colorectal cancers slightly and also certainly more sensitive for detecting those colorectal polyps, particularly the multi-target stool mRNA or DNA tests. And the reason is because it gets back to that compliance issue, is that if we offer people colonoscopy, essentially what we know is that half the people will decline for whatever reason. And so then we have half people not getting screened. And so then the question becomes, well, if they won't do colonoscopy, would they do a stool-based test? And if we offer that to them, we can get the participation rates up to 65, maybe up to 70%, but there's still 30% of people who are not participating. And if we think of colon cancer screening and any screening, not as a one-time event, thing that you do during your life, but actually something that you have to do regularly, or what we call a program, the compliance can actually go down even more. And so a test that would be really convenient would be really helpful. And a blood-based test really fits that mark. And so the hope would be that people would do blood-based testing if they won't do stool-based testing or they won't do colonoscopy-based. And that's kind of where we're positioning its use, because we don't think it's the go-to test because it's not as accurate as colonoscopy and it's not as accurate as the stool test, particularly for detecting those precancers. And as a gastroenterologist, I pay a lot of attention to those because that's an opportunity to get rid of cancer even before it happens. And so we can do that really easily during the colonoscopy. So then someone doesn't need to have surgery. They don't need to have chemotherapy. That's a life-altering thing that we've done for that person. Something that I get a lot of gratification at when I take out a large polyp. And I know I've changed that person's future because otherwise they would be getting colon cancer and having to deal with that. So because blood tests aren't ideal for doing that, we recommend them as being an option when someone's not willing to do colonoscopy, not willing to do the stool-based test. And we're really hopeful, given surveys that we've done of people, asking them if you are offered colon cancer screening and you won't do the stool-based test the colonoscopy-based test, will you do the blood-based test? And the vast majority of people will say, yes, they'll do that. What we don't know is how that's actually going to roll out when we add this to our current screening test, armamentarium. Are we really going to see higher compliance rates? So those studies are underway, and we're particularly intrigued with groups of people where historically we've had difficulty getting them to participate in screening. And so those are people who are in underserved areas, in rural areas where it's harder to get access to these tests.
And how close are we to having the blood-based test available in the clinic?
So the blood-based test is currently available. Provider can order it. It's undergoing a review by in different state Medicare, Medicaid organizations determining what its coverage will be. And also it's kind of in evolution in terms of what the commercial insurance will cover. So people need to be aware of that in terms of what the out-of-pocket cost could be. If that's not an issue for someone, they can pay for it. It's a little over $1,000. It retails for, I want to say right now, around $1,000 to $1,200. So obviously the hope would be with insurance coverage that it's going to be significantly less than that. In most states, if not all of them, it is a state mandate that insurance companies have to cover the cost of colon cancer screening. And so this test would be included as one of those if someone chose to do it.
Has there been any comparison of this test with the available multi-cancer early detection tests? I know they're trying to detect multiple cancers, but has there been any assessment of how they compare in terms of detecting colorectal cancer versus the test that you helped develop?
So the question there is, what about these multi-cancer detection tests, which are, well, that's the holy grail for cancer screening. Then that's a blood-based test that can detect not only one cancer, colorectal cancer, or some of the other cancers we screen for, like breast cancer, but 10, 20, 30, even up to 150 cancers in one blood test. So the performance when we look at those tests for colorectal cancer turn out to be about the same or actually a little bit worse than what the test that was developed in the Eclipse trial, which is called the SHIELD test. So they're not quite as good for colorectal cancer. They can detect these other types of cancers, but one of the limitations of the blood test that I haven't talked about but tends to be true for all the cancers that are detected by these multi-cancer detection tests is that the sensitivity for the early stage cancers is less than ideal. For the late stage cancers, they're actually quite sensitive. They can even be up to 100% sensitive, but those aren't the cancers that we want to detect with screening, because at that point, we haven't done anything that's going to be of particular value for a person, because they're still going to have to undergo all the things revolving around their cancer care that we wanted to avoid by having them do the cancer screening. So when we have a test that can detect cancers, we want to detect those early stage cancers. And if we look at the SHIELD test, it can detect around 65% of the early stage cancers. For the later stage cancers, which are the stage 3 and 4, it's 100%. I mean, there's even some value for detecting those stage 3 cancers because we can cure a lot of those people, but they still have to go through that surgery and chemotherapy surrounding the colorectal cancer. That's a limitation for these multi-cancer detection tests, is that their sensitivity isn't actually 65%. For the majority of those early stage cancers, it's actually around 20 to 30%. I worry partly because even though they can detect those early stage cancers, they miss a lot of them. And I worry that people will have those tests done and they'll have a false sense of reassurance. Like they've been screened, they're good, they don't have the cancers, but they actually do. And they actually have one at the time when you really want to know, because we know these cancers progress over time. And if we miss that time to catch them during that early stage, then they will go on to progress to later stage. And so that's a concern that we're trying to figure out what to do with these multi-cancer detection tests, because one of them is actually already commercially available and can be ordered, and people are getting this done.
You know, I think it's obviously wonderful that we have all of these advances in colorectal cancer screening. But I think for the general population, there are people who are still hesitant, people who have never been screened, and it can almost feel like there's too many choices. So what are key ways that you communicate with patients who have never been screened, who have reached the age where we would recommend screening? How do I make this decision? Should I do colonoscopy? Should I do a stool test? Should I do a blood test? How do I sort that decision making for myself? What is the simple message that you give to patients facing screening for the first time?
This has become a real challenge for the primary care providers, who are the ones who are really in the situation of initiating a cancer screening event. So I think what's become really important now more than ever is that now that we have these screening options, that we make sure people know the reason why to get the screening done. So I tell them, this is a common cancer. This is a cancer we can prevent. This is a cancer where if we don't prevent it, you're at a risk of about 1 in 20 of getting this. And if it does impact you, do it, it could potentially kill you, or at the very least will result in some significant complications if you have it treated when it's later stage. So you want to do this. That's one message I give them. And then that there are different options. And they basically say you can have the most accurate option, but the one that's the most difficult to do, and that's colonoscopy. There are other options that are less accurate but easier to do called stool-based tests. So my question for you is, are you okay with handling your stool? Because if you aren't, and that's the biggest barrier for people, then this isn't a good option for you. And if you're not and willing to do either one of those things, there is a blood-based test now that's currently available. That's the least accurate, but it's better than doing nothing. So we know that the worst thing you can do is choose not to do anything.
Obviously, research here is not stopping despite these advances. These tests will continue to evolve. Where do you see the technology going? What do you think our approach to screening will be in 5 years or 10 years from now? How will it be different from how we do things today?
Where I see things going is evolution of these blood-based tests, and those will become more sensitive for detecting those precancerous polyps. And so as a consequence of that, they will be elevated in terms of where they fit in terms of this menu of options that we have for cancer screening. Ideally, we could get to that point when they would actually have a sensitivity to those precancerous polyps that would be equivalent to colonoscopy. I think we still have a ways to go to be able to do that. There are other blood tests that are under development currently. There was another clinical trial that just published its results this year, which also was for detecting colorectal cancer, and it had a performance that was similar to the Shield test. So that may also help with some of the costs revolving around these tests. And then there's a third test that's currently in development by the same company that developed the Cologuard Plus test that we're hoping to find out results from the clinical trial later in this year. And the early results released by the company suggest that it might be about double the sensitivity for those precancerous polyps, which would be a significant advance in blood-based testing. So I think that these blood tests are going to get more effective. It may also be that we can screen for more than one cancer with the blood-based tests. And if those tests improve not only for detecting colorectal cancer, but other common cancers like breast cancer, that would make the blood test even more compelling, because you could do a blood test that would screen for, let's say, breast cancer, colon cancer, cervical cancer, skin cancer. That would cover a lot of things that are common cancers that we recommend screening for already. So I think that's super exciting. I think a big challenge for us as healthcare providers, though, still is if you do these tests, they are not diagnostic for colorectal pre-cancers. If you have a positive test result, you still need to get a colonoscopy. And the thing that's frustrating to me and a challenge I'm still trying to figure out is about half of people who have a positive stool test do not go on to get the colonoscopies done. And so that's another big barrier that we have to figure out with regards to how do we handle these tests and their use in the clinic.
So before we wrap up, are there any other final thoughts that you want to share? Any things that maybe we didn't cover that you wanted to highlight?
Pay attention to what else is going on in colon cancer screening. Know that this blood test is available. So if you've been reticent to do that, that's another option for you. There are other things that people can do to prevent cancer other than screening. And those have to do with healthy lifestyle, healthy diet. And so I really ask people lean into those type of things, because we know, unfortunately, that seems to be more common, that people are not living those healthy lifestyle diet. So they're eating more ultra processed foods, they're exercising less, not sleeping well. And that's just as important as doing cancer screening.
Thanks a lot, Bill. Always love the prevention messages. That's all the time that we have today for this episode of Cancer Speak. Thank you so much, Dr. Grady, for joining us today and for sharing your perspective on these exciting advances in non-invasive colorectal cancer screening. Special thank you to our listeners for tuning in. I encourage you all to read the article Top Advances of the Year, Non-Invasive Colorectal Cancer Screening Tests, available now in Cancer, and we'll include a link to the article in the show notes. I'm Dr. Christopher Lee, and we hope that you will join us again for future episodes of Cancer Speak.